made it to our last lesson in this EKG section, and we're going to finish strong and end it off with another deadly arrhythmia. So here we are going to talk about third-degree AV heart block. It is also called complete heart block. And this is a very deadly arrhythmia. And so when you see this, you have got to do something about it right away before our patients die. So let's go ahead and break it down and talk about it, okay? So in third degree AV heart block, or again, complete heart block, the electrical conduction is unable to reach the ventricles. So what happens is the SA node still sends that impulse, sends it across the atria so that the atria contract. And so because the SA node is still working, it sends it at a rate of about 60 to 100 beats per minute. Now, here's an AV node bundle of his right and left bundle branches and Purkinje fibers. So what's supposed to happen is the SA node sends the impulse, the atria contract, and then it travels down the AV node, down the bundle of his, and then to the ventricles, and the ventricles contract. Well, in complete heart block, this right here is preventing this signal from getting down to the ventricles. So what would normally happen is the ventricles stop contracting, do not do anything, and the patient dies. But because the heart is so smart, it picks up its own ventricular rate. Now, if you remember from one of our first lessons about the electrical conduction, I mentioned that the SA node beats at a rate of about 60 to 100 beats per minute. If the SA node stops working, the AV node picks up at a rate of about 40 to 60 beats per minute. And if the AV node quits working, then the ventricles pick up their own pace of about 20 to 40 beats per minute. Well, that's what happens here. The ventricles decide, why am I not getting the impulse from up above? What is happening? And since it's not getting it, the ventricles go, well, you know what? Forget it. I'm just going to be at my own pace, and I'm going to start my own electrical conduction. And so it does. And it does it at a rate of about 20 to 40 beats per minute. So the atria are sitting up here contracting like they should. And because that signal is not getting to the ventricles are down here contracting like they want at their own pace. There is no connection between these two. There's no relationship. There is nothing. This is what makes this rhythm so deadly, because the atria are contracting and the ventricles contract when they want. Well, it may not have enough blood in there. So cardiac output is significantly decreased. People cannot last in this rhythm very, very long. Something has got to be done about it as soon as possible. So let's go ahead and talk about it a little further, do the 6-step method, and break down the characteristics of third-degree heart block. So in step number 1, we got to look at the rhythm. Are we regular or irregular? So because it's third-degree heart block, we need to look at it a little differently. We actually have more P waves than we do QRS. So here's a P wave, here's a P wave. So I guess we can say this is a P wave, P wave. This is questionable. P wave, P wave, P wave, P wave, P wave, P wave. And there's probably a P wave somewhere behind the QRS. So what you need to, for the most part, the P to P waves are regular. So if I were to grab a paper and march out the P waves from here to here, I would be regular. Okay, again, for the most part. So the P to P intervals, the P to P waves are regular, because remember, the atria is still contracting at a good rate of about 60 to 100 beats per minute. So this is going to be regular. Now the ventricular rate, here we have a regular. Actually, if you look at this rhythm, if I were to march it out, I would have a regular ventricular rate. So our ventricular rate, for the most part, can be regular, but I know in this particular strip it is regular, but it is also usually irregular. The atrial rate, let's go with P waves. The atrial rate is, for the most part, regular. Okay, that is one way of being able to identify third-degree heart block. If your P waves are marching out and they are, coming when they should, and they have a regular pattern, but the ventricular rate is irregular and it appears when it feels like it, that's usually one of the key characteristics of it. In step number 2, let's look at the heart rate. And here we have 40 beats per minute. And again, usually with third degree heart block, our ventricular rate is slow because remember the ventricles pick up their own pace and it's usually not very fast. And number 3, we got to find out the P to QRS ratio. Now, I don't want you to get confused and think, but look, here we have a P wave followed by a QRS, correct? But because there's no association between the two, they're not connecting, they're not really talking, it is not measurable because we have more P waves. We have P waves here, P wave, P wave. This can be questionable P wave, P wave, P wave, P wave. So it is actually not measurable. And it is, other than it being not measurable, it is not a one-to-one conduction. We do not have a 1 P wave followed by 1 QRS. And in step number 4, we got to look at the PR interval. And that is definitely not measurable since we have more P waves than we do QRS. In step number 5, we do the QRS complex. So let's go ahead and do this one. So from here to here, we have about 1, 2, 3 boxes, so 0.12 seconds. So the QRS complex is usually wider in complete heart block. And in step number 6, we identify the rhythm. So we have third degree AV heart block, or again, another name is complete heart block. So let's go ahead and recap the characteristics of it. Our rhythm is, our ventricular rate for the most part will be irregular or regular. Our P to P waves are usually regular. The P to QRS ratio is not 1-to-1. The PR interval is not measurable, and the QRS complex is usually wider than normal. Now, in this rhythm right here, what you have got to remember is that it is completely blocked. The atria are doing their own thing, and the ventricles are doing their own thing. There is no communication between the two. This is why this is such a deadly rhythm, okay? And again, it's easier to remember it as complete heart block. And if you remember that, then you can understand we have a complete block between the two chambers. Or I'm sorry, between the upper chambers and the lower chambers. So let's talk about signs and symptoms and treatment measures for this. So because cardiac output is severely decreased in this rhythm, the clinical presentations are usually fatigue, dizziness, syncope. And because of decreased cardiac output, they will be very hypotensive, they'll have chest pain, and they will, for the most part, be hemodynamically unstable. Priority nursing interventions: assess the patient right away and determine the severity, and prepare them for a pacemaker. I have actually had a patient one time that was in third degree heart block, but they were completely asymptomatic. Blood pressure, his systolic blood pressure was in the 90s. His ventricular rate was hanging out for the 30s to the 40s. But because he was asymptomatic and not emergent, I did have him connected to the defibrillator and had him connected to the pacer leads. So if something were to happen, I just had to go push that button. But we were waiting for the next day for him to have a permanent pacemaker inserted. But I was ready. If he were to become unstable, his blood pressure were to drop, and he would be hemodynamically unstable, I was ready to pace that man. So that's the imperative thing with third degree heart block. You've got to be ready, and they will, for the most part, always get a permanent pacemaker because there's no way to just fix this rhythm other than a pacemaker. So the key points and your biggest takeaways from this lesson are to remember the abnormalities of third degree heart block. It is also called complete heart block. So the electrical signals are not reaching the ventricles. So there is a disassociation between the atria and the ventricles. So the atria are contracting at their own pace, and the ventricles are contracting at their own pace. So there's absolutely no relationship between the P waves and the QRS. They are doing whatever they want, and this causes significant decreased cardiac output. The main nursing interventions are to recognize the rhythm as quickly as possible and apply the pacing leads. And the only treatment is a pacemaker, temporary if unstable, and a permanent to get more of a long-term therapeutic results. So I hope that you guys have enjoyed this lesson and feel more comfortable identifying third degree heart blocks, again, or complete heart blocks. And make sure that you guys check out all the resources that are attached to this lesson. And make sure that you go back and go through all these lessons, especially the last three, the second degree type 1, second degree type 2, and the heart block. I know that a lot of people get them confused, but again, try to keep them simple and just pick out the differences between all three of them so that you can identify them. So make sure that you guys go out and be your best selves today. And as always, happy nursing.